Welcome to Integrative Systems Physiology. This is the Cardiovascular section, lecture number 2. Today we'll be focusing on cardiac conduction and automaticity as core drivers of the cardiac cycle and initiation and propagation of cardiac cycles throughout the lifetime. So if you recall from the last set of lectures, we had changed gears a little bit at the end, where we had started off from visible anatomical structures that are really the gross structures of the heart, including ventricular tissue, valve structures, and coronary structures throughout the heart, to then moving on to things that are less visible or somewhat invisible, which would include those structures that enable cardiac conduction, the initiation and propagation of cardiac electrical signals. And so just to recap on that, with the anatomy of cardiac conduction, what we have is in normal conditions, healthy conditions, all electrical impulses in cardiac cycles are initiated in the healthy heart at the SA node or the sinus node, sinoatrial node, and then those electrical signals are subsequently transmitted down internodal pathways to the AV node and the AV bundle, or the bundle of His as it is often referred to, and then subsequently move down both bundle branches and down the Purkinje fibers to ensure the rapid and coordinated contraction of both ventricles and the anterograde propulsion of blood to either the pulmonary or systemic circulations. So when we are looking at the speed of cardiac conduction, again, there is a method to the madness here. So, of course, there is a depolarization that occurs at the sinoatrial node that is very rapidly conducted through these internodal pathways to the AV node, at which point there is a pause. And so that pause and subsequent slower conduction down the bundle branches and down the Purkinje fibers is what allows for the atria to contract and have a bit of a kick right towards the end of diastole, which maximizes cardiac filling prior to the initiation of cardiac contraction and subsequent coordinated anterograde propulsion of blood out of the ventricles. And so that's where that pause and those slower conduction mechanisms really play an important role in dictating cardiac physiology. Similarly, when we're looking at the propagation of electrical signals within cardiac muscle and what we refer to as the syncytium, there we've got these gap junctions that connect different cardiomyocytes to ensure that there's very rapid propagation of these electrical signals and depolarization of cardiac cells to ensure the coordinated contraction of the atrial and ventricular tissues. So now that we've got this grasp on the overarching anatomy of the heart, we next want to ask the question, well, how are these electrical signals initiated, propagated, and translated into mechanical actions in the heart? So what we'll focus on predominantly here in this lecture is the initiation and propagation of these electrical signals within the heart. And so, as with all excitable cells, this is being driven almost exclusively by electrochemical driving forces. And so within cardiomyocytes, we have three primary ions that are responsible for the generation of the action potential and rhythmicity of cardiac cell and cardiomyocyte and conductive tissue firing. Those would be sodium, potassium, and calcium. And so, of course, critically, when we're looking at the extracellular concentration to intracellular concentration gradient, you can see that with sodium, there's a very large concentration gradient that's going to be driving sodium into the cell. With potassium, there is actually a very large a concentration gradient here. And with calcium, similarly, we've got a very large concentration gradient here as well. Now, I think the pivotal thing to evaluate here now is when we're looking at the membrane voltage, which in cardiac tissue is roughly minus 60 millivolts. You can see that when we look at that in the context of the the equilibrium potential for each one of these ions, which is calculated from the Nernst equation, which Dr. Linden discussed with you during his sections. What you can see is that for each one of these ions, they are going to be residing relatively far away from their equilibrium potential at various portions throughout the cardiac cycle, and subsequently are going to have very large electrochemical driving forces at varying portions of the cardiac cycle. And so this membrane potential here at minus 60 millivolts is maintained via ATP-dependent mechanisms, so active mechanisms, and sodium-potassium pumps. And subsequently, the ion channel opening of voltage-sensitive ion channels allows for the generation of action potentials and the rapid depolarization and cellular activation that's essential for coordinated cardiac contraction. And so when we start to think about some of these ion channels and what they do and how they function, if you look in chapters 5 and chapter 7 of the textbook that we have, there are a lot of ion channels and excitable cells. And I think it's good to be aware of this, to have some sort of awareness of the breadth and depth of investigation that's being done in these areas. But I would say, unless you're going to be focusing your career on studying ion channel flux, which is a noble calling for some, just not necessarily my cup of tea, I would say that you don't need to know the specifics except for in the context of what we discuss in class and in some of the later lectures and chapters. So really just focus in on where we highlight what you need to know, not necessarily this is very, very significant breadth and depth of description that's provided within the textbook. So again, I think when we're taking a look at this and saying, well, where are these signals initiated, propagated throughout the heart? Again, the sinus node is going to be the site of initiation of the action potentials and cardiac cycle in the healthy heart, going through the internodal pathways, going to the AV node and bundle of His, subsequently moving down through left and right bundle branches to the Purkinje fibers out to the ventricular tissue. And if it seems as though I sort of say this ad nauseum on multiple occasions, I do, and it is important to make sure that you can go through these things very fluidly and describe what that conduction pathway looks like. Now, importantly, when we look at each subcomponent of this conduction system, what you can see here is we've got depictions of the action potentials in the heart for each one of the cell types that's often activated throughout the cardiac cycle. And with the SA node, for example, sinoatrial node, you can see that here we've got a nice action potential, SA node subsequently being followed by atrial muscle contraction and conduction, the atrioventricular node having a shape that's very similar to what's observed in the SA node, Purkinje fibers looking somewhat more similar to the atrial muscle, and then ventricular muscle, of course, being a very close parallel to what's observed in atrial muscle. And what's important is when you look at these action potentials with much more detail and granularity, is what you can see is there's certain defining phenotypes and of these action potentials. And most notably, when you look at the SA node and the AV node and the Purkinje fibers in particular, you can see that there is instability during this diastolic phase in the resting membrane potential. So what you have is this overshoot beyond the normal resting potential, and then a progressive upslope back up until, again, we get over here and we reach firing, the threshold for potential for firing, and then propagation of another action potential. And so that's evident in the SA node. You can see that in the AV node. That slope is slightly less. Similarly, in the Purkinje fibers, that slope is lesser still, and in the atrial muscle and ventricular muscle, it is virtually non-existent. And so importantly, those three cell types with those unstable baselines of membrane potential are the cell types within the heart that have automaticity, or the ability to fire rhythmically and automatically and initiate the cardiac cycle. And importantly, when you look at these in maybe a little bit more detail, what you can see is that each one of these, as we mentioned, has a different rate. So the intrinsic rate of the SA node, for example, is between 60 and 100 beats per minute. The intrinsic rate for the atrioventricular node is between 40 and 60 beats per minute, and the intrinsic rate for the Purkinje fibers is 30 to 40 beats per minute. Now, this makes a lot of sense because what you want to have is the SA node firing at the most rapid rate, and so that will always be initiating your cardiac cycle. If this was reversed, then of course you would have the Purkinje fibers firing most rapidly, and you'd have discoordinated contraction based off of the flow patterns within the heart. So SA node always going to be firing the most rapidly. It's going to have the most rapid upslope here during this diastolic phase. AV node secondary rate, Purkinje fibers being the slowest. But again, having a series of fail-safes throughout this conduction system to ensure that should the SA node fail, then you don't just die because you don't have anything initiating a cardiac cycle. You do have a handful of backup mechanisms to continue firing and initiating cardiac cycles. Now, when we take a look at some of the currents that are regulating sinoatrial node depolarization in particular, and with more detail, what you can see here is that we have the membrane potential on the top, the fluxes of the various ions here on the bottom. And so initially, during the diastolic phase of the cardiac cycle, you can see there's this inward sodium current, which is a depolarizing current, and that results in the influx of sodium into the cell and results in progressive depolarization of the cell until it hits the point where it initiates an action potential, so that threshold for firing. And once that point is hit, then you end up having an inward calcium and sodium current. So a more rapid but still somewhat slow depolarizing current. So again, substantial influx of calcium here, of sodium at the beginning, calcium influx here throughout the systolic phase of the cardiac cycle, and then a return back to baseline with this the return towards the resting membrane potential, with that return to the membrane potential being driven largely by an outward potassium repolarizing current, which is depicted here. So really, it's those three ions and the fluxes of those three ions throughout the cardiac cycle that enables the rhythmic contraction of the ventricle, with most importantly, the most important component to this that's driving rhythmicity being the rate of leak of this funny current or this sodium current during the diastolic phase. So that is the sort of imperative component driving automaticity. Now, of course, what we would want to be able to do is to change the firing rate of the SA node so we could respond to various physiological stressors in vivo, and that can be done through here with these three examples being decreasing rate. Of course, you can also increase rate via reciprocal mechanisms, but when we're looking at the three mechanisms that can be used to decrease rate, for example, you can see here that first you can have a decrease in the rate of depolarization. So here, this upslope of this depolarizing current, or that funny current, is significantly reduced, and so it takes you a longer period of time to hit the threshold potential for firing of the action potential. So that will result in a slower rate over time. You can also have a more negative shift in the maximum diastolic potential. So during that diastolic phase, you're going to have an overshooting of a sort of more negative threshold potential, largely due to a greater potassium current. And so once you become more negative, then it's going to take you a longer period of time to reach that threshold potential for firing, even when the slope is comparable to what's observed under normal conditions. And so that will again reduce the rate of firing of the conduction system. And finally, you can have a positive shift in the threshold. So really moving from a threshold of, let's say here, minus 40 to minus 30, for example. And so what you can see here is now that even though you have the same rate of upslope, it takes you a longer period of time to reach that new threshold for firing of the action potential and ultimately slowing rate. Now, reciprocally, you can increase the rate of depolarization. You can have a less negative shift in the diastolic potential, or you can have a more negative shift in the threshold potential to accelerate cardiac tissue firing and accelerate heart rate, and ultimately respond more effectively to physiological stressors. So now, once we have this action potential that's being initiated and conducted and sort of carried through the cardiac system, the next question is, well, how is this pacemaker potential conducted through the heart and the cardiac tissue? And so largely what this is done through is via these intermuscular gap junctions. And so there you can see here that connecting all of these cardiomyocytes are these gap junctions. And the gap junctions are really inserted here between the two cells, and what that does is that enables the movement of a positive charge that is coming into this cell to subsequently be transferred to this adjacent cell, thereby accelerating its depolarization and the conduction of that depolarizing current down this line of cells from A to B to C in a much more rapid way than it would simply by having extracellular depolarization or passive flux of ions into the cells. And so importantly, this is just an absolutely critical mechanism with the appropriate placement of these gap junctions to enable the rapid conduction of this ionic signal down this chain of fibers. And so when we look at this with more sort of molecular detail, what you can see is that it is a relatively complicated process. And I don't want you to have to be forcing all of this to memory, but I do think it's important to take away a couple key talking points from this slide. And so one is that connexin 43 is one of the major gap junction proteins in the heart. And so here you can see here that it certainly is trafficked towards the intercellular space. It has to be actually effectively inserted here between these two cells, largely guided there via microtubules and this beta-catenin and cadherin complex, which assures the appropriate placement of the gap junction in these intercellular spaces. Now, when you have disease or substantial chronic stressors to the myocardium, what is often observed in those conditions is a near ubiquitous increase in oxidative stress. And so there, what you see is we have disruption of these microtubules, disruption of the EB1, and disruption of the beta-catenin complex, which disables the appropriate direction of these gap junctions to the intercellular space. And what you have then is cellular uncoupling and slowed electrical conduction throughout this syncytium of cardiomyocytes. And subsequently, you just have less effective, less powerful, less coordinated ejection of blood out of the ventricles, which ultimately physiologically manifests as an impaired systolic function of the left or right ventricle. So, collectively, that's about all I want you to take away from this slide. Not necessarily all of the other subunits here that are related to this to the formation of the gap junction. So, with that, we'll stop here, and we'll look forward to certainly having the next lecture on how many of these electrical potentials are translated towards electrocardiographic measures of cardiac function and how we can use some of those to both understand cardiac function and health and disease. Thank you.